The two series there, 5.3%, 9.3%. The problem with the T-shape is, look here, excellent results in this 10-year follow-up of only 11%. So this fracture has a very, very poor prognosis. So what does the T-shape mean? Well, essentially it's a transverse fracture line, as we can see there, as we've appreciated on the previous talk. And then it has a vertical limb coming down. And that vertical limb can be through the obturator foramen there. It can be further back through the ischial segment there, or it could be further forward through the pubic segment there. And these are difficult fractures. And if you think about it, both the ischial segment and the pubic segment are free floating. So there's no hinge between that and that anymore. There's no hinge between that and that anymore. There's no hinge between that and that anymore. So these are three potential bits of bone which are not attached. And your surgical approach for these depends on a whole host of factors. It depends on your line of the transverse fracture. It depends on where your vertical line is for the T element of it. It depends on the degree of column displacement, as we've already talked about. It depends on whether you've got a posterior wall element to it, and whether it's a significant posterior wall, and whether there's any marginal impaction. And again, with this, single approaches are limited for fractures where one of the columns is minimally displaced, or you think you can reduce the opposing column through that approach. However, unfortunately, most of the time you'll find that both columns are displaced. Okay? And in these cases, you may well want to think about an extensile iliofemoral approach, a dual approach, or a simultaneous dual approach. Now, I certainly, I don't have any experience with that at all. People talk about it. I don't have any experience with a simultaneous dual approach, because in my mind, what you're trying to do is you're trying to compromise on both approaches. So you want a little bit of Cocker-Langerbeck, you want a little bit of ilioinguinal from the front, and I think you'll compromise. So I don't tend to do that. In my hands, I usually use a dual approach for most of these, and I may consider using an extensile approach, such as the extensive iliofemoral. So here's a case here. This is a lady who was in a road traffic accident. She had other injuries. This was her acetabular injury, and you can see here that she has a fracture line which goes through the iliopectineal line. She has a posterior wall fracture there. She's got a fracture gap there. If you look at this relationship between the teardrop and the ilioischial line there, you can see that that is different to that. So this fragment is rotated round. The other thing you can see is that there's a break here as well, in the inferior portion of the ischium. We look on the obturator view, and we see that there's a disruption in the anterior column there. There's some comminution there. We see a comminution posterior wall. Hip is sublux, dislocated. The subtle finding there is this fracture line going here. So remember I talked about the vertical limb of the T. It can exit anterior, posterior, or through the obturator foramen. And here you can see it's exited at the back. On the oblique view, you can see that there's the posterior column fracture line going up there. There's the vertical limb coming down through there. You can see the posterior wall, which has been flipped up there as well. The anterior wall, you can see that there's a fracture line just going through there. So this is what I did. Intraoperatively, she was quite a big lady. I went into the front. I put a plate to fix and secure the anterior column. And then I flipped her and I did a posterior approach to fix the posterior column and the posterior wall fractures with spring plates there. And I thought it looked pretty reasonable until she came back at 6 months with that. So what I didn't mention before is that there had been three attempts at trying to reduce her hip. She came into us 2 days later and the hip was still dislocated. And maybe the blood supply was compromised from that, but this is the situation I was in at 6 months. So I made sure that there was no underlying infection. I ended up doing that for her. This is another case. On the X-ray, on the AP X-ray, there's not really that much to see. And you look at this and you think, hold on, is it just an inferior pubic rami fracture? Can't see anything else there. The rest of it looks okay-ish. And you get the obliques and you see that. There's the posterior column fracture line. There's a hint of an anterior column fracture line just there. So this again, and you can see through the obturator ring, obturator frame, that there's a fracture line in that plane there. So this again is a T-shaped fracture. And what I didn't mention on that view is this guy had a huge degloving and a graze on the outside of this leg. So I was forced, I looked at these X-rays, and I thought, look, ideally I'd like to go posterior. The majority of the displacement is posterior there, certainly on those views there. The anterior column doesn't look very displaced at all. So I want to go posterior, but I'm limited. This guy has degloving and he has a big graze over the lateral aspect. I can't go posterior. So in this case, I did go anterior, and I fixed everything through the anterior approach. And that's in there. So the T-shaped fractures, in summary, are very difficult to treat. The anterior and the posterior column elements of these fractures move independently of each other. These have a poor prognosis, and these usually require extensile approaches or dual approaches. We'll move on to both columns. So both column fractures, associated with both columns, where the articular surface is completely separated from the intact ileum. This accounts for about 25 to 30% of all acetabular fractures. And in these fractures, there's almost 50% excellent rate. We've talked about this. There are various treatment options for these. And if the hip shows secondary congruence, you can treat it non-operatively. You perform an open reduction internal fixation. You can, I don't advocate it, but there are certainly some people who think about percutaneous open reduction internal fixation. You can perform open reduction internal fixation and acute total hip replacement, or you can perform delayed total hip replacements. For the point of today's talk, we'll talk about fixation. So this is a typical associated both column fracture. There's a fracture line exiting here through the crest. There's a high anterior column fracture line. There's a lower anterior column fracture line. Sometimes you get this fracture line going into the sacroiliac joint as well. These fractures can sometimes be very difficult to treat. And the fractures which you can predict are going to be difficult to treat are these. So they're the ones where you have posterior iliac extension, so extension into the SI joint. Then you know that, hold on, this is a both column plus a ring injury, and this may be more difficult. If you have iliac comminution, you may not have any cortical guide to make sure that you can fit all the jigsaw pieces back together again. If the anterior column exits below the crest, so if it's an incomplete type fracture, you may have problems trying to reduce the articular surface of the acetabulum unless you complete the incomplete fracture line. And once you've done that, you'll find that everything moves into a better position to fix it. Or if you've got an associated posterior wall type fracture. So all of these things can predict that it's going to be slightly more difficult than the usual both column. This is what it looks like on a sawbone model. This is the high anterior column fracture line here. This is the lower anterior column fracture line. This fragment here, this trapezoidal piece, sometimes it can be triangular, is really important. Okay, when you're doing this approach, don't discard that fragment. Keep it. It's going to give you a guide as to reduction of the brim and the anterior column. Keep that fragment. And this is what happens when you put a bit of traction on. So there you go. That's with the femoral head just pushing in, and then you put a little bit of traction on, and that's what happens. Things seem to realign up again, and they look better than what they did without traction. The sequence of fixation of these fractures is important, and certainly this is something that I try and follow in most of these fractures. What I try and do is preserve that brim fragment, the triangular or the trapezoidal piece, and fix that back. I'll then go for the iliac wing, and I'll fix that. I'll then go for the high or the mid anterior column, and I'll fix that. I'll then think about fixing the posterior column onto the intact anterior column, or the high anterior column. I'll then fix the low anterior column, and then think about the posterior wall. And what we'll do is run through a case just highlighting all those steps. So there we go, that's the case that I just showed you. There's an anterior fracture line coming out into the crest there. There's a fracture line going into the SI joint there. There's that piece of articular surface. There's posterior column, which you can see rotated there. Low anterior column fracture line, probably fracture going into the posterior wall there as well. Okay, so the whole of this segment is not attached to the intact pituitary pelvis. This is the iliac oblique, and you can see that there's disruption of that joint there. The hip and the acetabulum is free floating. It's an associated both column. This one here, you can just about make out the spur sign that we talked about, and that's there. That's the intact bit of the ilium, which is still attached, and the rest of it isn't. So here we go, first view, with a shanks pin to apply lateral traction. And there is some degree of congruence there. And then my primary aim is to get that SI joint back. I want to get that SI joint back, and then I can build onto something stable. So I've reduced the SI joint, held it with a plate and 2 screws, and then a separate screw. I've got my lateral traction there. I've put a pin into the iliac crest as well to help me derotate that and get that back to where I want it. The crest fragment or brim fragment was there. You can just see it there. That's the piece I really want to keep. And I've secured it back there with a provisional plate and that screw holding that fragment. I've reduced my crest, so I need to fix that next. So I fix that with a screw, with a 3.5 screw, and then I'm moving on to that piece of the dome, which is attached to the anterior inferior iliac spine. We've got that reduced there, so I need to think about fixing that. And the way I tend to fix these is through a screw which is directed in the same corridor, same channel as your anterior inferior X-fix pin. So it's called the lateral compression type screw, 2 screw, the LC2 screw, which goes all the way down to the posterior ilium. So there you can see I've fixed the dome fragment and the anterior inferior iliac spine back with that. And then I want to reduce the posterior column. And I've done that with the posterior column screws there. And that's given me a final reduction. You can see the obliques there, so the iliac oblique, the posterior column screws, the plate from anterior, the LC2 screw going in that direction, and then the obturator oblique view there as well. That fragment there, that screw there is holding that posterior wall. So there we go, the final AP, obturator, highly incomplete. Thank you.
Thank you, Maz. Very interesting. Now, any questions, comments from the floor? Yes.
What's the cause of failure in the first case you showed, which dislocated after 6 months? I think you need a good fixation. What was the cause of failure? Why did it fail?
Yeah, so look, you know, surgeons are always protective and they always say I didn't do it. But, you know, I put my hands up. I did 2 approaches on her. She's a big lady. You know, could I have done everything through one approach? I would have had to go posterior. But I think the
back was inefficient fixation for the posterior fragment. That's why it's dislocated or subluxed.
Yeah, so I'm not sure. I thought, you know, on table, the posterior wall with spring plate was pretty well reduced and fixed. Maybe the fact that, you know, she was out for 48 hours. They tried 3 times to reduce her. I don't know.
It shows that this type of fracture is a bad prognosis.
It is.
Any question? Yes, Karan.
What is the average time for fixation for both columns? Is 2 lengthy operations?
For both columns, so associated both columns, or 2 approaches?
2 approaches. If you do anterior approach, then posterior approach. What is the average time?
Yeah, the average time is probably about 4 hours, 4.5 hours, something like that. So the anterior approach is in the cases that I've shown you, is pretty quick. It's probably about 1.5 hours, 2, and the other approach is probably about 2.5 hours. Because most of the fixation for these was from the posterior.
Well, Matt, thank you very much indeed. The chairman again. Okay.
Well, I think the T fraction has got the worst prognosis.